Kanna sir, good evening, sir. Rajgopal sir, good evening, sir. So friends, we have warmly welcome you for this today's evening PG clinics. Today we have two case presentations, one from PIMS Pondicherry by Dr. Srinivasan. The other case is by Dr. Vishnu from KIMS Hubali, kindly contributed by Dr. Ishwar sir and Dr. Guru Shantapa sir from KIMS Institute. And we have invited faculty, Professor Shilpa ma'am, Professor of Surgery from KEM and St. GS Medical College, and also in charge of the breast services at KEM. And we have Professor Arnima ma'am shortly joining us, and Professor Babita will be joining by 8:30 only because she has some meeting with the collector or something. So I also warmly welcome our own faculty, Kanna sir, Karnakaran sir, Rajgopal sir, and others who will be joining shortly. So we will go for the thyroid case first. We will have Dr. Vishnu to kindly share the PowerPoint and start your presentation. And we have the honor of having Manindran ma'am also. Ma'am, warm welcome to the forum. Are you able to share Vishnu?
Sir, good evening, sir. I'm presenting a CA breast case, sir.
I'm sorry. Then let Srinivasan go first.
Okay, sir.
Srinam? Srinivasan? Srinivasan, you have to remove your headset. I am unable to hear you. Remove it from your system.
Am I audible, sir?
Yes, now you are audible.
Sir,
Come closer to your mic, share your PPT and start your presentation. Abhay sir, good evening, sir.
Good evening.
Good evening, sir. Good evening, sir. Shinu, you have some challenges?
Sir, I'm sharing the screen, sir.
Go to the first slide, make it full screen. Tell about your unit chief, your head of the department, and start your presentation. Dr. Ishad is joining, ma?
Yes, sir. Sir is joining, sir.
Okay, okay. Come closer to your mic. Your audio is little difficult for the faculty to understand. Stay close to your system. Okay, I think we are able to see. Good luck to you. All the best.
Yes,
Please
sir.
start your presentation. Faculty, please take over.
Good evening, sir. Myself, Dr. Srinivasan, from final year postgraduate from Department of General Surgery, Pondicherry Institute of Medical Science, under guidance of Dr. Adi, Professor and Unit Chief and HOD, Department of General Surgery, PIMS, and my mentor is Dr. Ishad Ahmed, Senior Resident, Department of General Surgery, Pondicherry Institute of Medical Science. I'm presenting a case of thyroid swelling. Should I start, sir? History. A 43-year-old woman, housewife, hailing from Tiruvannamalai district, belonging to lower middle class of socio-economic status by Kuppusamy scale, presented with the chief complaints of swelling in the front side of the neck for the past 1 year. History of presenting illness. She was apparently asymptomatic before 1 year, following which she noticed a swelling in front side of the neck, which was insidious onset, progressive in nature. The swelling was initially 2 × 2 centimeter approximately, which progressed and attained the present size. The swelling was not associated with pain. No sudden increase in size of the skin. History of difficulty swallowing for the past 1 month. History of significant loss of weight present. 8 kgs in last 3 months. no history of dyspnea, hoarseness of voice present, no history of palpitation, irritability, increased appetite, heat intolerance, and disturbed sleep pattern, no history of menstrual irregularities, no history of loss of appetite, easy fatigability, constipation, and cold intolerance present. Past history, she was not a known case of diabetes mellitus, hypertension, tuberculosis, bronchial asthma. No history of previous irradiation to the neck. Personal history, she consumes mixed diet, normal appetite, normal bowel and bladder habits, normal sleep pattern. Menstrual history, she attained menarche at 13 years of age. LMP 6th October 2023. Regular menstrual cycle of 30 days duration, 3 days cycle. No history of passage of clots, white discharge, and associated abdomen pain. Obstetric history, she has 2 live children born out of normal vaginal delivery. History of sterilization 10 years before. Family history, no history of similar complaints in the first 2 generations of family members. Summary, 43-year-old woman, housewife, hailing from Tiruvannamalai district, belonging to lower middle class of socio-economic status with no known comorbidities, with no significant family history, presented with complaint of swelling in front side of the neck for the past 1 year. The swelling was insidious in onset, progressive in nature, not associated with pain, and with complaints of dysphagia present and significant weight loss present. No complaint of hypothyroidism or hyperthyroidism present. No other metastatic feature. Provisional diagnosis from history, I came to the provisional diagnosis of non-toxic goiter in the euthyroid state.
Srinivasan,
Yes, ma'am.
point number 1. When you're presenting any patient, do you say patient or you say lady? You don't use the word woman or female. They are completely not acceptable anymore. Secondly, what is the lower middle class got to do with this particular issue?
Based on the Kupusamy economic scale, socio-economic status is classified, ma'am.
Yeah, but how, does it in any way correlate to the symptoms that the patient has?
No, ma'am.
Yes or no?
No, ma'am. Socio-economic status is not correlating with this patient complaint, ma'am.
And you said euthyroid. So explain the significant weight loss.
Not able to hear.
You said patient is euthyroid, non-toxic. Explain
Yes,
the
ma'am.
significant weight loss based on your history.
The patient present with swelling, which is a longer duration of 1 year, and history of dysphagia is also present. So I'm suspecting malignancy in this patient, ma'am.
Which malignancy in that area gives dysphagia?
Any type of differentiated thyroid carcinoma or medullary thyroid carcinoma, like medullary thyroid carcinoma, ma'am.
Do you have any percentages to justify your statement?
This patient belongs to middle-aged woman with a swelling in the neck of longer duration of 1 year, which is progressive.
In a thyroid swelling, 1 year is not really a long duration. Patients come with 10 and 15 years of the swelling happening. I asked you, what is the percentage of medullary carcinomas who present with only dysphagia and no other local symptoms?
Sorry, ma'am, I don't know the answer.
So dysphagia is not really a classical symptom of thyroid malignancy unless it's an anaplastic variety. You've mentioned no stridor, no tracheal involvement, no nothing at all. And the esophagus lies posterior to the trachea. So it's very rare for it to get involved in a thyroidal pathology unless there's a whole lot of other things happening in the neck. There are certain benign conditions which can present with dysphagia, benign thyroid conditions which can classically present with dysphagia. Do you know what they are?
A long-standing multinodular goiter or a colloid
In my
goiter can-
career of 28 years, I've never seen an MNG causing dysphagia. And this is not long-standing. By your own saying, it is only 1 year old. It will be nicer if you don't know and you say you don't know, so I can give you the answer and you can progress.
Sorry, ma'am, I don't know the answer.
Yeah, so all the kinds of thyroiditis. And in women, Hashimoto's is specifically associated with dysphagia, but all kinds of thyroiditis can or may cause exacerbations with dysphagia and otherwise, which still doesn't explain the weight loss, but that kind of thyroid pathology can be associated with dysplasia or rarely anaplastic if the patient survives for that long. So I still haven't understood why this weight loss has happened. Maybe you'll have to figure out the reason why, but your present history does not suggest why it should happen.
Yes.
Okay, go on. Go on.
Yes.
Yeah, may I ask one question? For the same reason,
Yes.
may I?
Yeah, yes, ma'am.
Yeah. So for the same reason, housewife is now called as homemaker. One, and secondly, when you talk about loss of weight, you have to mention loss of appetite is there or not. Loss of weight with loss of appetite will go in favor of metastasis or
Yes.
malignant condition. If it is normal appetite and still the patient is losing weight, then it goes in favor of hyperthyroid state. So that differentiation is to be done on the basis of loss of appetite. Yeah, please.
Moving on to general examination. After obtaining consent, patient was examined in daylight with a female attender by the side. Patient is conscious, alert, oriented, and afebrile. ECOG score of 1, moderate, built and nourished. BMI 19.8. Vitals, pulse is 82 per minute. Regular rhythm, normal volume and character. Blood pressure, systolic BP is 130, diastolic is 80 mmHg, measured in right arm sitting posture, respiratory rate 16 per minute, afebrile, no eye signs, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy and edema. And moving on to local examination, inspection of the neck, trachea seems to be in midline, butterfly shaped swelling present in the anterior aspect of the neck, extending horizontally between the anterior border of right sternocleidomastoid muscle and 2 cm medial to the anterior border of left sternocleidomastoid muscle. Vertically, the swelling extends from inferior border of the thyroid cartilage to the 2 cm above sternal notch. On the left side, the swelling extends 1 cm below the thyroid and 2 cm above suprasternal notch approximately. On right side, a single swelling of size approximately 4 × 2 cm present on the left lobe of thyroid, swelling of size approximately 3 × 3 cm present. The swelling moves with deglutition and does not move on protrusion of tongue. Lower border of the swelling is seen. There is no overlying sinus scars or dilated veins. Moving on to palpation. The swelling was non-tender, no local rise of temperature noted. All inspectory findings were confirmed. On right side, swelling of size 5 × 2 cm present, extending from inferior border of thyroid cartilage to 2 cm above suprasternal notch vertically. And on the left side, the swelling of size 3 cross 3 centimeter extending 2 centimeter below inferior border of thyroid cartilage and inferior border 2 centimeter above suprasternal notch. The swelling has well-defined margin, firm in consistency, nodular in surface, lower border palpable. Carotid pulse felt on both sides. Trachea in midline position, no other swelling in the neck. Auscultation, no bruit over the both superior pole of the thyroid. Systemic examination, cardiovascular system S1, S2 present and no murmur. Respiratory system, normal vesicular breath sounds present. Abdomen, soft, non-tender, no organomegaly. Bowel sounds present. CNS, no focal neurological deficit present. A summary of the case. 43-year-old woman, homemaker, hailing from Tirunelveli district, belonging with no known comorbidities, with no significant family history, presented with complaint of swelling in front of the neck for the past 1 year, which is insidious in onset, progressive in nature, associated with the loss of weight and history of difficulty in swallowing present. No significant family history. No features suggestive of hyperthyroidism or hypothyroidism present, and no other metastatic feature. On examination, with the patient has ECOG score of 1, BMI 19.82, trachea in midline position, right lobe of thyroid enlarged to 5 cross 2 centimeter, and on the left lobe 3 cross 3 centimeter swelling, which is firm in consistency, nodular in surface, moves with deglutition and does not move on protrusion of tongue. Inferior border of the swelling is palpable with no other palpable lymph nodes. Provisional diagnosis, it's a case of non-toxic multinodular goiter and in the euthyroid state. I'm suspecting the malignancy in this case, sir.
If you're suspecting a malignancy, then it should come in your provisional diagnosis. You should say that it is a non-toxic multinodular goiter in a euthyroid state.
Probably of suspecting malignancy, ma'am.
Yeah, with the possibility of a neoplasm.
Possibility of neoplastic.
Yeah, or I would like to rule out neoplastic etiology.
Yes, ma'am.
Right?
Yes,
Go
ma'am.
on.
You said in this patient the ECOG scale, isn't?
Yes, sir.
Why did you tell us about the ECOG scale in this patient when your diagnosis is a multinodular goiter?
Sir, since I suspect neoplastic etiology in this case, I have derived a ECOG score for this patient, sir.
Okay, like in your provisional diagnosis, you have just written multinodular goiter. You have not mentioned anything even in the differential diagnosis as a malignancy. But if you want to give the performance status between the Karnofsky and the ECOG, which one you will like to offer?
Sir, I will go. Sir, I will do ECOG scores, sir.
No, ECOG if you are almost sure that it is a malignancy.
Yes.
Okay, Karnofsky is also for the malignancy.
Yes, Abhay,
But-
you want to say a comment? You want to make a comment?
Hello.
Yeah,
Yes,
Abhay, you want to make a comment?
No, I just want to ask him, why is he suspecting malignancy? Tell me on history and examination findings. At the end of your examination, why highly suspect malignancy and why not benign?
Sir, patient age profile, sir. This patient belongs to middle-aged group, 43 years age.
You think there are no benign goiters in 43-year-old? Exactly what Dr. Khanna is trying to ask you, I'm asking you in a different way.
Sir.
You ask for ECOG score, which is done in malignancy.
Yes, sir.
Tell me on history and examination why you're strongly suspecting malignancy. That's what I want to ask you.
Sir, history of loss of weight is present, sir. History of loss of weight and
What is significant loss of weight, my dear?
weight loss of 10% of total body weight in 3 months, sir.
Does it match this lady?
Sir, she has
No,
eight
my question is very clear. Does it match this lady?
Yes, sir, it matches, sir.
Okay, fair enough. So you are suspecting malignancy. Possibly that answers Dr. Khanna's question. Dr. Khanna can take over and Dr. Rao can take over.
Okay, another thing was, the first thing on the inspection of the neck. Can you go to that slide?
Yes, sir.
Inspection. The first thing which you have mentioned is about the trachea, isn't it?
Yes, sir. Yes, sir.
So that is the first thing you tell in a patient who has got presented with a swelling in the neck. That is the first thing we told. And how do you know it is the trachea is in the midline on inspection? How do you know on inspection that the trachea is in midline?
On inspection, I will look for the tracheal ring, sir.
Can you see in this patient there's a swelling there in the midline is there?
How often do you see tracheal rings unless the patient is completely emaciated? And not how often do you see tracheal rings in a normal lady?
Sir, tracheal position, we have to confirm only by palpation, sir. Inspection, approximately we can say that the trachea is in midline. By palpating the tracheal rings alone, we can confirm the position of the trachea.
So on inspection, what finding will be there? That the trachea is in the midline or it is shifted? Positive finding. Because on inspection, you cannot say that trachea is in the midline. Okay, it is not a finding on inspection.
Yes.
But what finding can be there which may say that the trachea is shifted to that particular site?
Suprasternal notch concavity will be present, sir.
No.
On inspection.
No, that is not correct. It is only the prominent sternocleidomastoid.
Yes.
Okay, if you find on one side on inspection that there is prominent sternocleidomastoid, probably the trachea shifted to that site. Okay.
Yes. Yes.
On palpation, you do not tell by palpating the tracheal rings that it is in the midline, but you palpate on the side of the trachea. You look at the gap which is there between the trachea and the sternocleidomastoid. On the side, your finger cannot go. You cannot dip in that area. It means the trachea shifted to that side.
Yes.
Okay.
Yes.
And the third way to know about the trachea, whether it is in the midline or it is shifted.
So, 3-finger test.
No, that you have done on palpation.
Yes.
The 3-finger test which is there, that's what I'm telling you. That you dip your finger on the either side of the trachea. If you are able to dip the finger on that side, it is probably shifted to the other side, where you are not able to dip your finger. And then auscultation. Okay, if you put your stethoscope there, normally you should hear the sounds in the midline. But if you hear the sounds on the sides, it means the trachea shifted to that side. Okay.
Yes.
What are the other points you missed on inspection? If you're, especially since you're considering that this could have a malignant etiology.
Uh, presence of other swelling.
No, that you've already mentioned. You need to tell me about the platysma sign, if it's present or absent. You also need to do the Pemberton's test, which is seen only on inspection.
Yes, but so lower border is visible on inspection.
So then my next question, can you have a well visualized lower border and still have a Pemberton's positive?
Yes, ma'am, we can have, ma'am.
When?
When retrosternally, the retrosternally ectopic thyroid tissues is present, that causes Pemberton sign positive, and with
you know, this is a very KM trait where you say the rarest things first. I thought it was a very KM trait, but no, that's not really so common. What else can happen? And now here you're saying you can see the lower border, so retrosternal extension is unlikely, right? But what could be possible?
Sorry, ma'am.
Plunging goiters?
Yes, yes, ma'am.
Yeah, which you will not see. I mean, you could feel the entire border, but there could still be that. So, but any which way, whether you this thing it or not, to complete your inspectory findings, you should mention both these signs, right?
Yes, ma'am.
Yes, Dr. Khanna, anything else you want to ask?
Okay. Now you have auscultated the thyroid, isn't it? Did you?
Yes, sir.
Where did you auscultate the thyroid?
Sir, on the superior pole of the thyroid lobe, sir.
Okay. Why on the superior pole? Why not on the inferior pole?
This superior pole will show increased bruit on increased vascularity, sir. So
he's asking why? Why only superior pole? Increased vascularity will be present on inferior pole also, but you will never get a bruit there. It's anatomical. The answer is anatomical.
The superior thyroid artery is the branch of external carotid artery, sir.
Okay.
So I auscultated on a superior pole of the thyroid.
Where is the superior pole? Against what bony structure would you place it?
Against the hyoid.
Hyoid bone. Hyoid is in the center, bacha. It's a very small bone right in the center of the neck.
Against thyroid cartilage.
Now you're telling me all the cartilages. No. Any vertebra? Anything? Okay, let's go back to Dr. Khanna's question. Why the superior pole? What is the part of the inferior thyroid?
Pole? Yeah, is there any artery on the inferior pole is there or not? Do you get an artery on the inferior pole?
No, sir. The only a superior pole has
the superior pole has the superior thyroid artery. Inferior pole, what vessels are there in the inferior pole? What vessels are there in the inferior pole?
Some branches of inferior thyroid arteries.
They come on the side. That is the reason, that's what we are again and again asking the same thing. On the inferior pole of the thyroid, you get only the inferior thyroid veins are there. There may be one vein or more than one vein may be there on the inferior pole. On the inferior pole, you do not have the inferior thyroid artery. inferior thyroid artery comes from the side behind the carotid sheath. Okay, so it is placed much more at the deeper level and it is not there at the lower pole. And that is why superior thyroid is present over the superior pole. You are always auscultating at the superior pole. Okay.
Yes.
So that is the reason for auscultation at the superior pole and not at the inferior pole.
Yes.
Another point is the superior thyroid is an end artery. It doesn't really branch too much, whereas the inferior thyroid gives multiple branches before it actually reaches the thyroid.
Right.
Right, and you can feel it against the bone, which is very difficult where the inferior thyroid is over a muscle bed. So it's very difficult to auscultate it in that position. Okay.
Yes, yes ma'am.
Yeah, Srinivasan, I have one or two questions to you. Number one, once the swelling is occupying both sides of the neck, what you said, butterfly, whether it's classical butterfly or whatever it is, you don't have to mention about movement with the deglutition and all. Number one. Number two, when you have a uniform enlargement of both lobes, mobility, it moves with the trachea. That is one important point you should remember. And if you can't see the trachea, that means isthmus is enlarged. Okay. If you don't see the tracheal rings, this has been discussed, tracheal rings, that means isthmus is enlarged. So you have to make a mention while palpating from behind the so-called the classical method. What is enlarged? What is enlarged means right lobe, left lobe size you are given. Isthmus is enlarged means tracheal rings are not palpable. Okay. Is it clear?
Yes.
Right? And without, do you have any evidence under palpation to suspect a malignancy in this patient? This is the same question which Dr. Abhay Dalvi, Dr. Ajay Khanna, everyone is asking you.
Yes.
Do you have any evidence to suspect malignancy? Palpation wise, inspection wise? Okay, I'll put it other way. What are the signs of malignancy? Signs.
Yes.
Signs.
Fine.
I think we've already told you all of them. You just have to repeat it.
Because I just want him to bring one important point. That's the reason. Yeah, just be related to mobility, madam. That's all. Yeah, please tell.
No, that's what. But he should at least repeat what he's been told. So we know that he's listening to us.
Sir, presence of other cervical swelling, presence of other cervical swelling, and
Good evening, madam. Good evening. How are you?
Can I come in here? Can I come in here?
Yes, sir.
For you,
Yes, sir.
If you permit me.
That's the
son had
You-
the
you
whole
got an
family
image.
got infected, no?
hello.
Okay,
Uh-huh.
Srinivasan,
Yeah.
how about the lateral?
Uh.
If you have a swelling which you can feel in the lateral aspect of
Great,
the neck,
Great, you didn't get the
and the
report.
thyroid is otherwise normal, what do you think it could be?
Please take care, madam.
Uh,
Only thing is, the
Lateral
common
aberrant thyroid.
guidelines they give is a lot of
Yeah.
fluids.
Lateral aberrant thyroid.
And
Lateral
Which is
aberrant thyroid.
Which is what kind of a malignancy is that?
Probably it will be from papillary thyroid carcinoma.
You have to be more confident of what you know, na? You're looking so say it with confidence, at least the answers you know.
Yes, ma'am.
Yeah. Okay.
Srinivasan,
You answer Dr. Shenoy's question, and then I think we can move on to
all the examiners are trying to tell you, don't give a diagnosis based on the final diagnosis which you know. Please understand. Okay.
Yes.
You know the final diagnosis.
Yes, ma'am.
So, in other
Can I
words,
come in here?
some consistency, some hard nodularity or restricted mobility of thyroid spreading beyond the capsule. That's the time you get whatever you said, no weight loss and other things, lymph nodes or whatever bone metastasis, rapid increase. Actually, in your patient, nothing is there. So, and finally, you have made the diagnosis non-toxic goiter euthyroid state. Means what? there are two things. Non-toxic goiter, euthyroid state means what is that you wanted to convey? Correct?
So I
uh,
think
can
if he
be
didn't know the final diagnosis, that would be his standard. And I keep telling this to all my students that please don't read the papers, please don't know the diagnosis, because you get completely flummoxed like this and you get yourself into trouble. So clinically, this will be your euthyroid multinodular goiter. Clinically, it is that. You get a surgical surprise, it's different. But your clinical diagnosis will be what you've written on the screen.
Dalvi sir, you are raised your hand, sir.
Yes,
Sir.
yes.
Dalvi's
My basic question, because now the thing has gone on to discussion between whether it is clinically malignant or no. If you feel that it is clinically malignant, I'll agree. If it is not, why did you try to hear the bruit when it is non-toxic? See, in exam, students should say, I don't know, quickly.
Yes. Sir, to rule out hypervascularity and thyrotoxicosis, I want to
Now,
elicit.
wait. Clinically, is the patient thyrotoxic? No.
No.
You wanted to complete the examination, so you asked for bruit.
Yes.
Examiners have already told you the reasons why it is superior pole.
Yes, sir.
Tell me anatomy, superior pole supplies what and inferior thyroid artery supplies what?
Superior thyroid artery is a branch of external carotid artery.
Wait. Now, again, you are getting into soup. Now, tell me all branches of external carotid artery. See, never open your mouth.
Yes.
Because it is branch of external carotid, that's why you can hear bruit. Bruit is heard only in toxicosis or hyperdynamic circulation. Correct or no?
Yes, sir.
Correct. Rest of the things you have answered. It is more superficial. Other examiners told you inferior thyroid comes from behind, etc. I'll give you homework. Go back and read McGregor's anatomy, and it will tell you why bruit is better heard on superior pole except for an anatomical location of that artery.
Yes.
Okay, that's your homework. I'm not going to give you answers.
Yes.
So now my question is, you kept on saying branch of external carotid artery. Tell me branches of external carotid artery from its origin.
Sir, I remember some branches from external carotid artery or facial artery.
No. Don't run from here to there. There is bifurcation of carotid artery into internal. The first branch is ascending pharyngeal, which can come from external carotid or from bifurcation. Second is superior thyroid. Third, fourth, fifth, sixth, seventh, eighth. If you don't know, get out.
Sorry, sir, I don't know.
Yeah, now why I'm telling you this is, when you keep on insisting on saying that it is branch of external carotid artery, this question is bound to come.
Yes.
This question is bound to come.
There is a mnemonic for this. At least when we were students, there was a mnemonic for this. I think so. It's easier if you remember those mnemonics. So I'm sure they're available. I don't want to say it on this platform, but there are enough mnemonics available to remember this, the 7-8 branches that it has, right? It's also got to do with the physiology of the superior thyroid. What Abhay was asking, the percentage of blood supply that the superior thyroid provides compared to the inferior thyroid. So all those will give you your answers, right?
Yes.
Can we proceed to his management?
Please.
Yeah, because we have like 10 more minutes, I think, on this. Yes, Srinivasan, continue.
Yes. Yes,
Now
ma'am.
you said this is a non-toxic thyroid goiter. Multinodular thyroid. Okay, now invest. What would you manage? What would you like to do?
Ma'am, I will like to proceed with imaging with the
Straight away imaging. What's the first test you do for all thyroid
thyroid
swellings?
function test. Sorry,
Say
thyroid
that.
function test. Thyroid function test to look for the TSH, T3, T4 levels, and I will go with the imaging study with the ultrasound. In ultrasound,
So if your TSH is a little high, a little low rather, and your T3 and T4 are normal, is there anything else you would like to rule out if the TSH is still high? Is low, sorry, the TSH is low and T3 and T4 are normal?
it is subclinical hypothyroidism.
Hyper? When
TSH is low.
low, TSH is low.
Subclinical hyperthyroidism.
So that could happen, which could explain all these other issues. So, okay, so you do your thyroid function, then you go to imaging. What imaging would you like to do?
Ultrasound scan. Ultrasound of neck.
Yeah, what all do you see in that?
In ultrasound, I will look for any other thyroid nodule and any other thyroid nodule vascularity and vascularity, calcification, and other neck nodes, and I'll also assess the thyroid score for that thyroid score.
So tell us about the thyroid score. What kind of vascularity? What all makes it a low score or a high score?
Thyroid score consists of 5 components, ma'am. Consists of composition, echogenicity, shape, and shape, margin, and echogenic foci. Each carries scoring, ma'am, around 0 to 2, and it varies with the components, ma'am. And based on it, thyroid score is given. Thyroids 0 to 1 is benign, and 2 to 3 is benign, ma'am. And based on the thyroid score, the the swelling is divided into benign.
No, Srinivasan, go slow. What are the points you look for? What is the first thing you see? Okay, you see whether it's multinodular. There are some nodules you missed on. That is one. Then what do you see? In the nodules, first thing, what do you see?
Septations and vascularity.
No, no, that's not all that you see. The vascularity is later on, because you talked about the thyroid scoring, right? So the nodules can be, how can they be classified? You give points according to the classification of the type, the contents of the nodules, right? So what contents will give you what scoring?
Cystic or spongiform, or hyperechoic or hypoechoic.
No, that is later. Cystic, spongiform,
the septations,
mixed, and solid.
Solid.
So each of them, depending on whatever. So if it's a solid, you give it 2 points. If it's purely cystic, it becomes a 0. Then the next one you said was?
Echogenicity
Yes. So anechoic you said, then
and anechoic, hyperechoic or hypoechoic lesion, ma'am. Hyperechoic low score, hypoechoic high score.
so it's hyperechoic and very hyperechoic. So then
Very-
that very hyperechoic gets another 2 points. Then the next thing,
Shape
shape of what?
of cells, whether taller than wider.
Yeah. So if it's taller than wider, is it good or bad?
Bad.
Bad. So that gets 3 points. Right? Next.
Margin, ma'am. Margin, whether the margin is ill-defined or well-defined, or calcification is present or
No, calcification is another story altogether. So well-defined margins, ill-defined margins,
ill-defined.
okay, irregular margins, and then you have an extra thyroidal spread.
Yes.
That's
Yes.
the worst case scenario. So that again is 3. I mean, I'm giving you the maximum points for each scoring. And then you come to your microcalcifications, which is what?
Echogenic foci.
So
Echogenic foci.
you could have benign calcifications in a long-standing goiter, which are large, just like the breast. They're large calcifications. Okay, so you can ignore that. Then you can come to microcalcs. Then you come into peripheral rim calcifications, punctate calcifications. So if you mention Thyroid, you must know the scoring system.
Yes.
Right?
Yes. Yes, ma'am.
Yeah. So you have to look at all of that. Plus, you have to look at the vascularity and the resistive index, especially if you're suspecting follicular, not in this case, but any which way. Right?
Yes.
So all these points you have to talk on when you're talking about ultrasound of the thyroid.
Yes.
Right?
Yes, ma'am.
So that's one more image. And what else would you like to do?
Based on the thyroid scoring, I will go for fine needle aspiration cytology of most suspicious nodule and dominant nodule. I will go for fine needle aspiration cytology, ma'am.
What is so special or different when you're doing a fine needle aspiration of the thyroid vis-a-vis any other structure in the body? Do you do the same methodology, or is there something else that you would do specifically for thyroid FNAs? Okay, how do you normally perform an FNA?
Fix. Well, I will use syringe, needle and syringe and
Needle and
aspirate
syringe is a very vague terminology. In surgery, you have to be specific, Raja. So what needle, what syringe?
8. Sorry, ma'am.
You never done an FNA in your 3 years of surgery? You use a 2 cc syringe and you use a 24 number gauge needle. And you do not apply suction when you're doing a thyroid FNA because it's a very, very vascular swelling. You can cause an hematoma.
Yes.
And preferably always do it ultrasound guided.
Yes.
Yes?
Yes, ma'am.
Okay. So you did an FNA.
In FNA, give a cytological presence, whether presence of any
mnemonic or external
and presence of any colloid colloid pattern of follicular cells can be seen in FNAC, ma'am.
Okay, that's one thing you can see. So that will take you to your non-toxic multinodular goiter. So yes, suppose you have got that on your FNA, that it says it's a colloid goiter. Next, what will you do?
Sorry, ma'am, I didn't get.
So your FNA is showing colloid, that it is a colloid goiter, multinodular goiter, right? Now, how will you manage further?
If FNAC shows goiter and patient is symptomatic, I'll go. Patient is symptomatic of dysphagia, and I'll go with total thyroidectomy.
So you said patient. So again, if the patient has dysphagia, are there any other tests you would like to do before you take up this patient for surgery and get nasty surprises?
I'll go with do X-ray. Sorry, video laryngoscopy for to.
No, that is part and parcel. So I spoke about a type of thyroiditis, right?
Yes. Yes, ma'am.
What did I say?
Right. The case of benign.
Which kind of thyroiditis did I mention?
Riddle's thyroiditis.
No, I didn't mention Riddle's. Riddle's was put on the message.
Hashimoto's thyroiditis.
So Riddle's, you will again have symptoms. Patient would have given you some symptoms of, some systemic symptoms. Hashimoto's, you may not have any symptoms at all. And a good 30% of our women population has a positive testing for Hashimoto's. So what is the test that we do?
Anti-thyroid peroxidase antibody and TSH antibody.
Yeah, so you would want to do those things as well, right?
Yes, ma'am.
Okay. And you would like to look for other causes of the dysphagia. It's unlikely to have been because of the thyroid. So you would like to find out other causes of dysphagia.
Yes.
And is it dysphagia or odynophagia? What does she say?
Difficulty in swallowing, ma'am.
So that is called what?
Dysphagia. Dysphagia.
And what is odynophagia?
Painful swallowing, ma'am.
So she has no painful swallowing.
No, ma'am.
So then do you want to work up the patient for that, or do you straight away want to take up the patient for surgery?
I will work out for the preoperatively for dysphagia, ma'am.
Which
is upper GI endoscopy. Upper GI scopy.
Yes.
I will do preoperatively.
Yeah, because your symptoms of the thyroid don't seem to match the symptoms of the dysphagia, right? She could have two pathologies.
Yes. Yes.
Right?
Yes.
Okay. Then what would you like to do?
Yeah, madam, with your permission, just one question at this stage. What is the age of your patient? 43.
43.
So women dysphagia, and if anemia is there, what else you suspect? Especially since this discussion is going on here. Quick.
Yeah, nice question.
Yeah, because it is important you write.
Yes. Absolutely.
In a case of female, I will with anemia and dysphagia, I will suspect Plummer-Wilson syndrome.
So in other words, those things have to be evaluated. Okay, it's fine.
Yes.
Fine. Thank you. Good.
Yes. No, I'm just talking because everybody else has gone quiet. You're more than welcome to come in. Yeah, go on, Srinivas.
Okay.
We need to wind this up.
Tell what is the extension of the ultrasonography in the thyroid?
Ultrasound can be used to do ultrasound guided image guided FNAC, sir.
No. After the ultrasound, you have done the thyroid scoring in. Does the thyroid include the vascularity or not?
Yes, resistive index we can find.
No, thyroid doesn't include the vascularity. Okay.
Yes, sir.
So when you add the duplex in that, then you look for the vascularity of that. You know? Then after that, what is the next step which you can do after the duplex? You know elastography? Have you
Sir,
heard the name
yes.
elastography?
Yes, sir. Yes, sir. I have heard, sir.
Yes, so you can do the elastography for that, no?
Yes.
And that will also add whether this patient is having a benign nodule or it's a malignant nodule.
Malignant.
So does all the nodules they require the FNAC?
FNA, dominant nodule and suspicious nodule requires FNAC, sir. And
So
in
as per your thyroids, which nodule will require the FNAC and which will not require the FNAC?
sir, by thyroids, score of 3, 4, and 5 will require FNAC, sir.
Yes.
If
So up to 2, it is not required. No? If it is 0 to 2 is there, it is not required to go for the FNAC. Okay. Did you understand that?
Yes, sir. Yes, sir.
From 0 to 2, it is not required to go for the FNAC. From
Yes,
3 onwards, you are required to go for the FNAC.
Yes, sir.
Right. Now, when your cytologist report the cytology report, what does he give? What does he report?
He gives the scoring based on Bethesda scoring system, sir.
Right. So Bethesda scoring system. And what is that?
It grades the cytology of the score into 5 categories, sir. 5 categories.
6 categories are there. Okay. There are 6 categories. Okay, and you go ahead with that, yeah.
6 categories such as benign etiology.
Before the benign, what is there? What is the first? It is non-diagnostic or unsatisfactory.
Unsatisfactory or non-diagnostic.
Yes.
And second one is benign.
Yes.
And third is AUS or FLUS.
Yes.
And fourth one is follicular neoplasm.
Yes.
And fifth one is highly suspicious of malignancy.
Yes.
Yes.
Right. So it gives, pathologist says it is a cyst is there. What is the treatment? Cyst.
A complete cyst with the isoechoic needs only drainage, sir, if symptomatic. If
Drainage or
requires,
something else? Does it require the drainage?
sorry, aspiration, sir.
You understand the difference between aspiration and drainage?
Yes, sir.
So you do only the aspiration.
Yes, sir. Aspiration, sir.
Yes. How many times you can aspirate?
3, sir.
Yeah, 3 times. Okay.
3 times, sir.
Yeah. Again, if it is still refilling even after 3 times, then you have to excise that.
Yes, yes.
Or if it is a, mixed type of the cyst is there where there is also solid component is there, then also you go for the excision of that.
Yes, sir. Yes, sir.
Now
So,
tell if it is a
can I
case
just
of,
ask one more question on
Yeah.
this thing? So, if it is grade 3, grade 4, and grade 5, are there any criteria for doing an FNA?
Yes, ma'am.
I mean, other than the said criteria,
size
anything
is
else
also
that the ATA recommends?
ATI recommends size as a parameter to do FNA, ma'am.
Yes.
Grade 5, thyroids 5, if the lesion is more than 1 centimeter, we have to do FNA, ma'am.
1.5
1
is what ATA says.
1.5.
Yeah. And for this thing, grade 3?
Grade 3 lesion of size more than 2 centimeter.
2.5 centimeters. You have to have a grade 4 also between, na?
Yes.
So 2.5, 2 and 1.5.
Yes,
Okay.
ma'am. Yes, ma'am.
Yeah, you were asking something, sorry. Dr. Khanna?
Okay. Now, in this patient, if you are planning for the total thyroidectomy, let us say, you are planning for the total thyroidectomy.
Yes.
Will you do any X-ray?
X-ray of neck, ma'am. Neck, sir.
Why you will do the X-ray of the neck?
To confirm the position of trachea and to
What X-ray of the neck?
What X-ray you will do? Just one X-ray or more X-rays?
two X-ray, anteroposterior view and lateral view.
And this is a very classical MRCS question. Okay, what all do you see on an X-ray neck in a thyroid?
I will look for any tracheal compression, any for Scabbard's trachea, and for preoperative assessment of difficulty in intubation, difficulty in extubation.
Meaning, how can you make that out? You know, if you go systematically, then you won't forget. Talk about the thyroid first, then talk about the trachea, and then talk about other structures that are visible on an X-ray neck. So in the thyroid, what all do you see?
Any calcification.
Any calcifications?
Any calcification.
First, you would like to see the margins of the thyroid, because a lot of times when you do a CT scan, the patient is lying down. So almost 30% of them will show a report of a retrosternal extension. So you see the lower margins of the thyroid, you see for calcifications. Then you see the trachea you mentioned. What else will you see? Which your anesthetist would be very eager to know.
Short neck or adequate neck length.
Short neck is clinical. What are you going to see on the X-ray?
Sorry, ma'am, I don't.
You need to see the cervical spine. Whether there is any spondylosis, anything that is a stiff spine, whether the spinal curvature is gone, because then the neck extension may not be possible, or the anesthetist may have to look into an awake intubation and other things. Right?
Yes, ma'am.
Okay.
Scabbard trachea you see on the lateral X-ray or the AP view? Scabbard trachea. No, you cannot exactly see, but you can assess. In which view you will assess the scabbard trachea?
Anteroposterior X-ray.
Lateral view, you know?
Yes.
Because in the scabbard trachea, what happens? There's the ring, they collapse. Okay, so there's a thinning of the diameter of that. The AP view, you are only seeing the deviation of the trachea.
Yes.
While in the lateral view, you are seeing that there's a compression of the trachea is there.
Yes.
So in the typical scabbard trachea, there's a compression of the trachea is there.
Yes.
Okay, so that is why you see it on the lateral view. Okay. Right. So
apart from the ultrasound finding of the thyroid nodules, what other things may give you a hint for malignancy, and which area you look in the neck? Apart from the thyroid, all have been discussed now: size, nodule, or more than 2 centimeter, 2.5, 4 centimeter nodule, etc. Srinivasan, you are there?
Yes, sir. I'm here, sir.
You would have told, but apart from the thyroid, other than the thyroid, sonologist, what else you look here in the neck?
I will look for cervical lymph nodes, sir.
Be specific, postgraduate. Yeah, tell me which cervical means, which area you look.
On the level 2
So
3 and 4.
correct. And
Yes.
yes, what about the pretracheal, that area?
Level 6, sir. It is also present, sir. Level 6 node, sir.
So can you just tell me quickly for a sonologist how they pick up this level 2, 3, 4, like in relation to what structure is that? Yes, you are right, but this is some question they ask you usually.
Jugular vein.
Jugular vein.
Jugular vein.
Which jugular vein? Jugular vein.
Upper, middle, and lower jugular vein regions.
Which jugular vein? So always
Internal jugular.
So don't expect the examiner to go. So external jugular vein or internals. Don't get internal jugular vein. Okay.
Yes.
Professor Jairam Shana has joined us. Sir, you have any few questions you can ask, sir. Jairam Shana is Jairam. You are there? Yes. Yes. You are muted.
Hello.
Yes.
Hello. Good evening. Good evening, Rajgopal.
Yes. Good evening. Please.
Good evening. Thank you. I was just I just joined. I'm late. Very sorry for that. I had some other work.
Okay.
Yeah.
No problem.
I was just entering there when they were talking about the scabbard. Just for the sake of it, what is the meaning of a scabbard? If it's better they know the meaning of a scabbard, because some people mistake scabbard as a person. I've heard people talking about a scabbard trachea. Such things. What is the meaning of a scabbard? Is anyone aware of that?
Scabbard means what?
Softening of tracheal rings.
Yeah, softening happens, but the literal why is it called a scabbard trachea? I'm going back. Sorry for that, because I've heard sometimes students claiming that it is a scabbard trachea, although it is a person's name, something like a Lichtenstein's operation, like that.
So he's already given you a hint. It's not a person. So it is a thing. Now, what is this thing that is scabbard?
Yeah.
Sorry, sir, I don't.
Yeah. No, it is actually the sheath of a sword.
Right.
The trachea almost gets compressed because of the softening of the rings, and it gets converted into something like a sheath of a sword.
Yes.
It is not a person.
Yes.
If someone is mistakenly considering it as a person's name, then I just wanted to intervene and correct it. That's all.
Yes.
Can we get into the I think the next case should have been started by now. So can we just get into the basic management, Srinivas, 2 lines of the management, and then we'll stop this.
Yes. For this case of non-toxic multinodular goiter, this patient is in a euthyroid state, and patient is I will evaluate for.
You've done all that. What is your surgical option?
Total thyroidectomy, ma'am.
Why total?
In this patient, both lobes are involved, ma'am, and to prevent recurrence.
What is the percentage of parathyroid damage in total thyroidectomy? And recurrent damage? It's a benign disease. Is there a better option that you can look at?
Near total thyroidectomy.
You do a near total, right? Now define a near total.
Removal of both lobes and isthmus, leaving 1 to 4 gram of tissue in the tracheoesophageal groove.
It's not 1 to 3. And now near total is pretty much accepted to be removing all visual thyroid tissue, maintaining the posterior capsule so as to minimize damage to the parathyroids and recurrent. Okay. In fact, for a lot of malignancies now they have started doing near total because the morbidity is very high with the total. So certain specific malignancies, you can still go in and do a near total on the opposite side or whatever else. And after that, what would you like to do?
Based on the I'll look for biopsy report whether
It's
it is
come, your FNA is come colloid goiter. So is the biopsy going to change much?
no, ma'am.
So you already know this is a colloid goiter. Now what will you do? You operated on the patient. Then what?
Follow up and send the thyroid supplementation.
When will you start?
4 weeks later, we'll start on.
You want this patient to undergo hypothyroidism for 4 weeks before you start her on a replacement? What are the guidelines? You started at 72 hours post surgery. And why do you do that? For that, you need to know the half-life of the various thyroid hormones. Right?
Yes.
Which is the active thyroid hormone, T3 or T4?
T3.
So what is its half-life?
Hours.
It's a few hours.
5
So
hours.
72 hours is when it drops to other things. So you don't keep, nowadays you don't keep them waiting for 4 weeks. That's only when you're handling a malignancy and you want the TSH to be level. Otherwise you start the patient within 72 hours with replacement therapy.
Yes.
Dr. Shenoy, Dr. Khanna, if anybody else is there, or we stop this and move on to the next case.
Do you know any minimal invasive technique for a young girl who has a thyroid nodule? Can we do some minimal invasive techniques for that? Any idea?
Minimal incision thyroid surgery and transoral thyroid surgery. Through the vestibule of mouth, we can do thyroidectomy.
Okay. What is Baba? Baba technique?
Sorry, sir. I don't.
Baba is bilateral breast and bilateral axillary approach.
Yes.
So you are not working at the neck,
Yes, sir.
but that is called a remote access surgery, isn't it?
Yes.
Right. Apart from the surgery, do you know any other minimal invasive technique for nodules which are likely to be benign?
Radioactive iodine.
No, apart from the radioactive iodine in the medical treatment,
Yes.
do you know any other some percutaneous techniques? Percutaneous ethanol, percutaneous laser, percutaneous radio frequency ablation, percutaneous microwave, all these are the percutaneous techniques which are also tried for the thyroid nodules, which are more likely the benign one, not the malignant. People have tried also for the malignant one, but they are mainly for the benign.
Yes.
Okay.
Yes.
Right. I think we can go to the next.
Yes, sir. Yes, sir. Srinivasan, I think you have read well, but I wish you get little coherent. That is what is missing. Otherwise, you should see the earlier thyroid videos in this channel. A lot of times the seniors here have discussed thyroid well. So you should have a flow. Right? The problem is you are probably biased with the pathology report which you have received after the completion of surgery. From the beginning, it is okay to clinically stick on to what you see and hear as a history from the patient. And then once probably you can convince the examiners the post-surgical histology became malignant. That's why I worked on this. So no need to be just fixated to the thoughts that you are dealing with the malignancy. You try to fitting in. Many times thyroid as such, unless the lesion is very big or there are anaplastic features or and they may not be presenting with malignant symptoms at all, unlike other cancers. All right. So I guess probably that was the one which was delaying your initial process of examiners repeatedly putting you questions on what are the clinical things, what are the history things. But then no, when the examiners ask what are the history-wise malignancy, pointing things towards malignancy, you should be able to pull out 1, 2, 3, 4, 5 like that. Because these are all pretty common questions. You cannot struggle or make examiners to more and more ask questions. Here in this forum, we have 1 hour. In reality, you may not have that much time and you have to quickly move on to the things. So your answers have to be more precise. All right. And do you have any questions? Any doubts to be clarified by the examiners?
No.
So thank you. Your Professor Adi was my assistant professor when I did my PG. So I gave my kind regards to him. And faculty, I should put on record, he is kindly contributed by Dr. Irshad. Irshad happened to be our early presenters during the Corona time. He has now become the faculty in Pondicherry Institute of Medical Sciences and he has insisted and brought him. Thank you, Irshad, for considering us.
Thank you, sir.
Thank you.
Thank you,
And,
sir. Thank you for your.
Friends, we move on to the next case. We also warmly welcome Papita ma'am. And I could see Dr. Ishwar sir joining some time back. Thank you,
Yes,
sir.
sir.
Thank you for joining. And we move on to the next case. Do we have Vishnu?
Yes, sir. Yes, sir.
Yeah, please share your PowerPoint. Again, Vishnu is from Ishwar sir's and Guru Shantapa sir's unit department from KIMS Hubli. Good luck to you.
Thank you, sir.
Your slides are fine. Please start your presentation.
Good evening, respected faculty members. Today, I'll be presenting a case of lump in the breast. Myself, Dr. Vishnu, is postgraduate student, Department of General Surgery, KIMS Hubli, and my guide is Dr. Ishwar Hosmani, sir, and my HOD is Dr. Gushandapa Yalagachin, sir. So here is a patient, Mrs. X, age 65 years, female, from Nargund, a daily wage worker. She came with chief complaints of lump in the right breast since 2 months. Coming to history of presenting illness, she came with complaints of lump in right breast since 2 months, which was initially of size of 2 crores 2 centimeter, and which was noticed by her while taking bath. Gradually progressed since the last 2 months to the current size of 6 crores 4 centimeter, with recent onset skin changes over the swelling since 3 weeks. There is no history of any nipple discharge. There is no history of bony pain. There is no history of breathlessness, cough, or hemoptysis. There is no history of similar lump in the opposite breast or bilateral axilla. There is no history of abdominal distension or jaundice. There is no history of headache, vomiting, blurring of vision, or seizures. There is no history of loss of weight or appetite. There is no history of fever. There is no history of pain, and there is no history of any trauma. Coming to past history, she is not a known case of diabetes, hypertension, asthma, or tuberculosis. Coming to the family history, there is no history of similar complaints in the family or history of any ovarian, GI, or prostatic cancers in the family. Coming to menstrual history, she attained menarche at the age of 12 years. She had regular cycles of 28 days with 5 days of menstruation. She attained menopause at 10 years back. And coming to obstetric history, she is para 4, living 4. All were full-term normal vaginal deliveries. She has breastfed all children with both breasts, with cumulative breastfeeding for more than 2 years. And age at first childbirth is 23 years. And she was tuberctomized 30 years ago. Now, coming to personal history, she takes mixed diet. She has increased appetite. her sleep is sound, bowel and bladder habits are regular, and there is no history of consumption of any addictive substances. And I'd like to summarize from the history. She's a 65-year-old postmenopausal female presented with a painless progressive lump in the right breast since 2 months, with recent onset skin changes over the lump. Sir, shall I proceed with it?
I have one question.
Yes, Abhay, please ask.
Can you tell me so much on in history you have asked?
Yes, sir.
What is the importance of history of seizures?
Sir, in late stage, it can metastasize.
Late. Wait. You said late stage, right?
Yes, sir.
You think this is already late?
No, sir, she has giving only 2 months history. So
How
brain
does-
metastasis to rule out brain
I can
metastasis.
understand your diagnosis carcinoma breast at the end. How does it spread and how does it relate to your history?
Sir, usually it is hematogenous spread only, sir. But in the late stage, it can cause deposits in brain cell, which can present as seizure, vomiting, and
See,
case of raised ICDs.
look. You have worked in the ward for maybe 2.5, 3 years,
Yes,
and you are talking theory. You're not talking practical at all. That's the problem that I always come on this show and try to tell. Tell what is common. How does cancer spread? By principle, tell me.
sir, usually lymphatic spread, sir.
No. That's where the issue is. Let me give you. First, cancer cell go by continuity. Means in the adjacent tissue.
Yes, sir.
Second thing is contiguity into adjacent organ. Then comes the lymphatic spread. Then comes the vascular spread. Then comes the coelomic spread. Have you heard of all these things?
Yes, sir.
So when you answer in your exam, any malignancy spread, these 5 things you remember. And all the PGs should remember this. Continuity, contiguity, lymphatic spread, vascular spread, and transcoelomic spread. My question, last question to you is, which are the 2 organs which are known to have transcoelomic spread?
So ovarian malignancy, sir.
How does it happen? Transcoelomic means it has to go to another compartment.
Yes, sir. Through the rectus, sir, rectus.
I think Dr. Ishwar wants to ask something.
Yeah. The sir is spreading from one organ to another organ through the peritoneal cavity is going there. Now, what are the organs and what is the route for that?
Sir, through the lymphatics.
It is reverse lymphatic flow as it is known, but that's okay. Only 2 organs, breast and stomach, are known to have a so-called transcoelomic spread. There are controversies, it's okay. For your and other PGs listening, for any malignancy, as far as spread is concerned, when question is asked to you, again I am repeating, continuity, contiguity, lymphatic spread, vascular spread, transcoelomic may not come into picture for other organs. Understood?
Yes.
Okay. It's a
Okay,
very
now
clear
Vishnu?
answer.
Sorry, go ahead.
No, it's okay. I finished.
No, so now that all this has happened, tell me what on your summary allows you to mention the fact of seizures and jaundice. Which aspect of your summary justifies you asking for a history of jaundice and seizures?
Actually, she gives history of only 2 months, sir.
I'm not asking you what negates it. I'm asking you what arrows it towards you are asking that history. I mean, I feel that the history you asked is correct. So now you justify what part of your history allows you to ask those questions.
Maybe, ma'am, she has noticed the swelling since only 2 months, ma'am. Maybe swelling was present since.
You've been repeating yourself. Is there anything along with the swelling that is present
She
in
has
her?
noticed recent onset skin changes also she has noticed, ma'am.
Which means what?
So it's advanced, ma'am.
It's advanced. There's a word for it.
Locally advanced, ma'am.
Okay. So in locally advanced breast cancer, what is the percentage of metastasis at presentation?
74 of 60, the ability to put the
No, Vishnu, madam is asking, what is the purpose of asking history of seizure and history of jaundice?
So I'm justifying his asking it. I'm asking him to tell me the reason why he's asking it. I would ask for it, but I know why I'm asking. So he should also know what is the reason that you ask for this history.
What is suspecting other way?
And he's disappeared from the screen. I can't see his face only.
Metastasis, ma'am.
What is the percentage of patients who will have metastasis at presentation in a case of locally advanced breast cancer? If you answer that, then you will justify your own questions.
I'm almost 5%.
Yeah, sure. I wish we were so lucky. It's 30%. 30% will have metastasis. And if the patient is present with seizures, what kind of cancer, what kind of IHC or markers are you looking for? Or which kind of breast cancers tend to metastasize to the brain?
Really, medullary carcinoma.
Don't ask me a question to my question, yaar. Answer.
Sorry, don't know.
ER, PR, HER.
Which type?
Triple
What
negative,
IHC?
basal type. Triple negative, basal type.
No. Good night, Abhay. Okay.
One or two questions, madam, at this stage to Vishnu.
No, let him finish answering my question. He's not answering.
I'm HER2 positive cancers.
Yes.
Yeah.
So if you have a patient who is presenting with seizures, I would definitely like to rule out a HER2 positivity, right? So every time you ask the patient a question, you should be able to justify why you are asking it, right? Yes, Sarji, Dr. Shenoy, you were asking something.
No, madam, my history is simple like this. If it is present, it is better to rather than there is no end for. That's what we tell our students. To
But
that
we will ask if they don't mention it, we will ask them anyways. So it depends on the examiners, na?
No, because what happens is in a usual in a practice of no, let us not have a controversy, but low backache is the most commonly asked question, which you should highlight that.
Yeah, you should highlight. But if he wants to get a gold, or he is aiming for something really good, and if the examiner happens to be a breast surgeon, they will pull on you if you don't ask it. So it's better, I feel, that they ask and they are able to justify why they are asking. You can't just ask to complete a picture, but if he can justify that 30% of them are likely to be HER2 positive in an LABC, and 30% have metastasis at presentation, then I know that he's aware of what he's asking. And I think breast has become so common. I mean, every single person should know everything basically about breast cancer. So these are the basic tenets that you need to know on breast cancer, right? You should know why. And you should list it in order of commonality. Like Dr. Shenoy said, the first thing would be a fracture or, bone pains. Then there could be maybe jaundice late in certain cases. And so seizure should come right at the end of the thing, But yeah, So depends on examiners. Safer to say all, but justify why you're saying it, right? Okay.
Ganesh, is it good enough at least to tell in one word there is no symptom suggestive of metastatic disease?
What happens, sir? Because in the exam moment, the jaundice word comes, obviously examiners will bounce on it. Even in a carcinoma stomach and colon, if the liver metastasis occurs, jaundice is a late feature, so advanced because so much liver has to be destroyed. So
May I add a word here? Hello.
keeping all these things in mind, why jaundice, why portal, all these so many issues will come because when the
Did he mention? Did he mention about lung respiratory system? I'm sorry, I didn't see that part.
Yes, ma'am, I have mentioned.
Okay.
But
So
what
which is the
happens?
commonest respiratory symptom? Breathlessness.
Breathlessness, ma'am, breathing difficulty.
Because of what is the commonest etiology?
Ma'am, effusion because of pleural effusion, ma'am.
Okay. Yeah, so jaundice
As
is really
Dr.
a very
Dalvi
late
was asking.
manifestation in this thing. Yeah. Okay. Blurring of vision. Why?
That also increased intracranial tension, ma'am.
No.
That is what I was trying to tell, that these are not really required, all that big list. That's what I meant.
See, if you want to hit a gold, you will say all this and you will say it with reasoning. Blurring of vision happens because of deposits in the retina, again seen in HER2 positive patients. Okay. So if you know all that stuff, then you must with a lot of confidence say all these points. But if you are not aware and you're just saying it to complete the story, then I strongly recommend against it. Yeah, but you have time to read. So now you will be able to justify why you're saying all these things. Again, there's no history of weight loss or appetite also doesn't really happen much in breast cancer. So these are not common features for breast cancer, right? In fact, what is the opposite thing that happens in breast cancer in terms of weight? How old is this lady?
65, ma'am.
Yeah. So what is the thing that is more likely to be seen? In fact, it's said to be a predictor of breast cancer.
Obesity, ma'am.
Yeah, and more elegantly,
Postmenopausal obesity.
postmenopausal. What kind? What ratio? The hip waist ratio. Yeah. So multiple studies have proved. And why does obesity tend to have a higher incidence of obese patients have a higher incidence?
Ma'am, there will be a peripheral conversion, ma'am, to estrogen.
So more fat cells, more hormones,
fat cells will be
right?
converted to estrogen, ma'am. So there will be
again, instead of writing no history of weight, you should have mentioned that there is no postmenopausal weight gain.
Yes, ma'am.
Right? Yeah.
Vishnu, as Dr. Dalvi was asking, the type of the spread which occurs, you know, what are the special type of the spread which has been named in the case of breast cancer? Named concepts are there for that. You know, what is the Halstead concept of spread of breast cancer? You know, what is the Fisher concept of spread of breast cancer? Okay, Halstead concept initially, you know, many years back, he always thought, Dr. Halstead always thought that it is always a loco-regional disease. It will start from the breast, then it will go to the first lymph node in the axilla, then to the second, and then to the third, and then it will go to the supraclavicular and then go to the systemic. Okay, so that's why he was always doing what was called as the Halstead radical mastectomy. But in that also, he was not taking care of the internal memory chain in that. Okay, which is also direct spread from the breast cancer. So Mr. Fisher came with that concept, and that is called a Fisher concept of the spread for the breast cancer. That breast cancer from the day one is a systemic disease. And that is why all the concept of the neoadjuvant and the adjuvant chemotherapy came into consideration. But probably both were not correct. The third concept came, what is called a spectrum concept. So spectrum concept says that the breast cancer is both loco-regional as well as it's a systemic disease. And that is why you always hit the breast cancer by surgery as well as by the systemic treatment. Okay. So these are various concepts which are there. You know what is the tumor doubling time of the breast cancer? Tumor doubling time of the breast cancer. One cancer cell becoming two cancer cells. Okay, it's around 100 days, approximately 100 days. And you know, for a palpable 1 centimeter lump in the breast, which is there, how much time does it take? For a palpable 1 centimeter breast lump? It takes around 5 years. So what you are feeling a centimeter lump, which you think is a very early breast cancer, it is already there for 5 years. Because it takes 30 doublings to be palpable 1 centimeter lump. So 1 cell becoming 2 cell, 2, 4, 4, 8, like that. It takes 30 doublings. Okay. So in fact, from the very beginning, the breast cancer which is there, though we say it is a early breast cancer, it's already a systemic disease there because it can occur at the 22nd doubly, the patient can have the metastasis. Okay, that is the behavioral problems which are there in the breast cancer. And that is why nobody is able to understand that what is the breast cancer. And that is why there is so much of literature which is available for the breast cancer. Okay. Yeah, you can go to your examination now.
Coming to general physical examination, patient is moderately built and nourished, conscious, oriented. Pulse rate is 78 beats per minute, measured from right radial artery with regular rhythm, normal volume. BP is 110/70 millimeters of mercury, measured from right brachial artery in supine position. Respiratory rate is 20 cycles per minute. Pallor is present. There is no icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. And BMI is 27.5, and their ECOG score is 1. And coming to inspection, the breast appears to be asymmetrical with the left breast with respect to size, contour, and shape. Fullness is noted in the lower outer quadrant. There is a partial retraction of nipple noted on the right breast and lies at a higher level compared to left side. Skin over the right breast is normal, except for a dimpling of size 1 centimeter, which is noted in the lower outer quadrant of the right breast, 1 centimeter below the nipple areola complex. And on leaning forward, both breasts fall freely, but right breast is at a higher level compared to left. And PUD orange appearance is noted over the lump of the right breast. And there is no dilated veins, scars, ulcerations, nipple discharge noted over the right breast.
Photo?
Sorry, sir. On overhead abduction of the arms, the dimpling and nipple retraction becomes more prominent, and the inframammary region appears normal, and the supraclavicular and infraclavicular regions appear normal, and there is no right side arm edema noted, and there is no visible swellings noted in the right side axilla. Coming to palpation, there is a lumbosized 4x3 centimeter noted in the lower outer quadrant of right breast, which is non-tender with ill-defined borders, irregular surface, which is hard in consistency. It moves with the breast tissues. The skin is not pinchable over the lump. And making the pectoral muscle taut, the mobility is not restricted. And when making serratus anterior taut, the mobility is not restricted. And there is no evidence of any nipple discharge. This is the diagrams. And coming to percussion, there is no dullness noted in the parasternal region on the right. And coming to examination of right axilla, axillary lymph node size 1x1 centimeter is noted in the central group, which is non-tender, hard in consistency, and mobile. And the examination of right supraclavicular region showed no evidence of any palpable lymph nodes. And coming to examination of left breast and axilla, it's normal, and examination of spine is normal. Coming to systemic examination, CVS, S1, S2 is heard, then there are no murmurs. And in coming to respiratory system, there are bilateral normal vesicular breath sounds present, and there are no added sounds. And per abdominal examination, soft, no tender, no guarding, no rigidity, and no organomegaly. And coming to CNS, higher mental functions are normal. And coming to provisional diagnosis, I'd like to diagnose it as carcinoma of right breast, T4B, N1, M0, stage 3B.
Wonderful team, wonderful achievement, and wonderful all-round performance. Will keep their hopes alive.
Vishnu, what do you find in the abdominal examination in a patient with this type of the breast cancer?
The ascites can be seen, sir.
Okay,
So
what
shifting
else?
dullness can be elicited.
That
Sir.
is ascites, no? Shifting dullness ascites, yes.
Yes,
What
sir.
else?
And also maybe hepatomegaly.
Okay. What else?
And on general physical exam, maybe if jaundice may be present.
No, abdominal examination. I
Only.
am asking the abdominal examination. One, you said hepatomegaly. Second, you said ascites.
Yes, sir.
What else
And
can be there?
maybe some other abdominal mass like any ovarian malignancies also involved. So lower abdominal mass can be felt.
What is that ovarian mass?
Sir, Krukenberg's tumors.
Okay. Is your patient premenopausal or postmenopausal?
Postmenopausal, sir.
So can it occur in the postmenopausal or not?
Unlikely, sir.
But it can occur. No? So how does it occur in the postmenopausal? What was the theory for the premenopausal and what is the theory for the postmenopausal? Is it more common in premenopausal or postmenopausal?
Premenopausal, sir.
Okay.
Transcelomic spread, sir.
Transcelomic spread was there. And in the postmenopausal, what is the spread? The retrograde lymphatic spread is there. Okay.
Yes.
What else you can get on the abdominal examination? If you do the digital rectal examination, can you find something?
Blummershell.
Yes, it can be there. Can you get anything in the umbilicus?
And Sister Mary Joseph nodules.
Yes, you can get that. All right. In the chest, what finding will be there in the breast cancer? Chest finding.
Goes from like this, push them back, kick them to hang back, and then brings in the full ball as well. Now it's a kilogram performance for the worst.
You already said in the history she can have a breathlessness. How to confirm it?
Decreased breath sounds will be there, sir. And decreased air entry will be there, sir. If pleural effusion is there.
What do you infer? Why there is a decreased breath sound and why there is?
It can be due to pleural effusion, sir.
Yes. Or it can be because of?
If there is a metastasis.
Pleural effusion and consolidation. So how will you differentiate whether it is a consolidation, the pleural effusion? On clinical examination.
Sir, in pleural effusion, there will be decreased, and on percussion, sir, there will be a dull note on percussion, sir.
So that will be there also in the consolidation also. It will be dull on percussion.
And the deviation of trachea may be noted, sir. If pleural effusion is there, trachea may be deviated to opposite side, sir.
Not necessarily. Depends upon how much the fluid is there. And it will not.
And sir,
it will push.
Vocal resonance and vocal formitus, sir. If it is a pleural effusion, if it's consolidation, vocal resonance, vocal formitus will increase, sir. If pleural effusion, it will be reduced, sir.
Yes. So that is the difference between the consolidation and the pleural effusion. Yes. If the brain metastasis there, what finding can be there?
Sir, the papilledema can be there, sir.
Good.
If on fundus examination.
Yes. Right. Now, if you want to see for the vertebral metastasis, like the lower backache is supposed to be one of the commonest area, where you will palpate the vertebra. Clinical, I'm asking you, no? Where you will palpate the vertebra.
So in the paravertebral region, sir.
Paravertebral. Not on the vertebra, but on the paravertebral. Why? Why
spasm can be muscular spasm can be recognized.
What is the earliest place of metastasis in the vertebra?
Transverse process.
Not in the transverse process.
What you get to the side of the spinous process? In the center, they have a spinous process. By the side of the spinous process, what part of the vertebra will be there?
Foramina.
Foramina.
Facets.
What is that area called as in the vertebra? Pedicle. No? That is called a pedicle, where the transverse process gets attached to it. You know, on the plain X-ray, how does the pedicle looks like? Like if you see a APB or the lumbar vertebra, how does that look like, the pedicle? It looks like a bull size. You see a rounded two structure on the either side, what is called a bull size. Okay. Madam? You are muted. Madam, you are muted.
Yeah. Can we move on to management now? It's already 10 o'clock.
Yeah.
Yeah, Vishnu, how do you manage?
I like to do triple assessment, ma'am. Actually, after clinical examination, I would like to do radiological examination and followed by histopathological examination, ma'am. In radiological examination, I'd like to do sonomammography, ma'am. And followed by I'd like to get the histopathology, ma'am, or needle biopsy, ma'am.
You only shown an USG here. So you do only sono-mammo, you would not do a mammo on her?
Yes, ma'am. Mammography and ultrasound breast, ma'am, bilateral breast with axilla.
Okay. So what's your mammography showing?
Ma'am, mammography shows a well-defined radiodense lesion, ma'am, with lobulated margins in the retroareolar and the lower outer quadrant of right breast, ma'am, suggestive of a Birat's 5 lesion.
Yeah. So when you say well-defined, no, you don't have the mammo plate. When you have a well-defined radiodense lesion, does it give you any idea about the IHC of the patient?
If it is well-defined, it can be a luminal A or B.
Don't ask me questions, answer
Yes,
confidently. So it's more likely to be luminal A.
Luminal A.
And if it's absolutely ill-defined, irregular.
Ma'am, triple negative, ma'am.
Yeah. So just by looking at a mammo, you can get that information. I'm not saying that. So you can, it just helps you further. Okay.
Yes, ma'am.
Okay. After this.
And coming to USG of bilateral breast with axilla. Right breast shows a ill-defined hypoechogenic lesion with the speculated margins measuring 5.4 into 4.2 centimeter between 6 o'clock and 7 o'clock position. Suggestive of Birat's 5 lesion with enlarged right axillary inflow measuring 1 into 0.8 centimeter. And left breast.
What else would you look for in a mammography?
Opposite breast and axilla.
No, in the same breast.
Multicentricity should be seen.
Yeah, so you definitely look for that. Right.
And in medio calcifications can be seen, ma'am, microcalcifications. And in medial lateral oblique view, axilla also can be visualized.
Right. Okay, so you have to see the architecture,
yes,
the lump, the calcifications, whether it's a dense breast. Okay, then the extra breast, that's the axilla, and any fat planes. So I keep saying that A, B, C, D, E, F. That's what you see on a mammo, right? Okay, then you've done this. Next.
Then I'd like to go with the histopathological examination, ma'am.
FNAC?
Yes.
You do an FNAC?
Actually, corneal biopsy is the treatment of.
Yeah, so then why even mention an FNA? Who does an FNA now? You're not going to mention an FNA in the exam, okay?
Yes, ma'am.
So you do a? Yeah, you do an FNA of the node, but you definitely not do an FNA of the lump.
Yes,
right? Okay. Have you done a core at all or not?
Yes, ma'am. Yes, ma'am. The corneal biopsy showed, ma'am, sections shows bits of breast tissue showing fibrocollagenous tissues, trauma and terminal duct lobular units, ma'am, with malignant ductal epithelial cells arranged in groups, clusters, and in singles.
Okay, don't read out from the screen. Okay.
And the impression is a feature suggestive of infiltrating ductal carcinoma. And
What else on core?
ma'am, got immunohistochemistry, ma'am. It shows ERPR negative and HER2 positive. And K67 50%.
Little rare, no? Okay, how will you manage it?
I would also like to do the metastatic workup, ma'am. So, like to get a chest X-ray, spine, USC abdomen, and pelvis, ma'am, and LFT also.
No, 1 second. You would like to do a
metastatic workup, ma'am.
Yeah, tell me about what all constitutes a metastatic workup.
Ma'am, I'll get one chest X-ray, ma'am.
Okay.
And spine, ma'am, DL spine, ma'am.
Okay.
And USC abdomen and pelvis, ma'am.
That's all.
And LFT.
This is an LABC. LFT you do in early breast cancer. In a LABC, you want to do a metastatic workup. So ideally, you have to do a CT of the abdomen if you're not doing, and a CT chest, HRCT, and because it's in HER2, you would like to do an MRI brain. In addition to the bony this thing, or if you have the facility for a PET scan, then you do a PET scan, which would take in consideration everything. Instead of having a bone scan, you ideally have to do a bone scan, an HRCT, CT abdomen, and a imaging of the brain. Right, so it's easier to mention, and PET is now part of the protocol. The NCCN guidelines mentions PET as part of its protocol, right?
Yes.
Okay. So what is your story after that? What's the metastatic workup?
Ma'am, if it is no metastasis, ma'am.
Local disease.
Yes, ma'am, local disease.
Okay,
so,
how will you manage it?
So I'd like to give neoadjuvant chemotherapy, ma'am. 4 cycles of AC and 4 cycles of paclitaxel.
60-something-year-old lady, you want to start AC without any investigations.
Cardiology, this 2D echo should be done to rule out any cardiac issues, ma'am.
So you want to start AC on a HER2 positive lady?
Even we can also.
There are multiple studies which tell you about other neoadjuvants, right? Would you like to start Herceptin? Trastuzumab?
Yes, ma'am.
What do you give with trastuzumab in a neoadjuvant setting? You give taxanes and trastuzumab. So you can give either docetaxel or docetaxel, or you can give Pacli.
Yes,
okay, Pacli has to be given weekly. So 1, 2, 3rd week, 1st week, Pacli, Herceptin. 3 weeks ke baad the same thing. So 4 cycles of trastuzumab as neoadjuvant. Okay, and then see the size of the tumor and then give AC if required. Again, gauge and then decide for whatever process you are saying, right? So if the tumor shrinks by more than 60% after your neoadjuvant, 60-70%, what next?
We'll plan for MRM.
Why?
She's a good responder, ma'am, so we can plan for.
Yeah, she's a good responder. So you want to do an MRM?
Or we can give option of.
There is no option. What is better for the patient is good. What are the studies showing?
Continue.
Vishnu, it is a locally advanced breast carcinoma. Other than MRM, can you have any other plans?
Sir, we can give
at the end of your you're saying there's 70% response, the skin becomes supple and malleable, your mammo shows a downstaging of the disease.
Can try BCS with tax.
Yeah, we all need to go now. Yeah, so multiple studies have now shown that BCS is a viable option for good responders. Okay, it helps in multiple studies have come. I mean, there's no two ways about it. So you could offer her, and age doesn't become a criteria. It's because it also improves the quality of survival and distance metastasis and what have you. Okay, so you have to give the patient the options of both, right? And post-surgery?
Radiotherapy
Any hormonal therapy?
and Herceptin only. And since
Continue it for a, yeah. I think we'll end with this, right? Anybody else wants to take over? But I think
Well, sir.
I think we should allow the student to ask any doubts. Babita ma'am, would you like to ask any questions?
Sir, I have one or two questions. Can I ask
Yes,
now?
madam. Yes, madam, please.
Doctor, why are you telling it is T4B?
Ma'am, in inspection, ma'am, actually purely orange appearance was there, ma'am. So skin was not pinchable, ma'am, on palpation.
What are the things you will come under skin involvement?
Ma'am, purely orange appearance, ulceration and satellite nodules, ma'am.
Ulcerate and satellite nodules. Here you are, because of the POD orange, you are telling
Yes, ma'am.
T4B.
Yes, ma'am.
You demonstrated, purity orange, was it there or
On inspection only it was visible, sir, purely orange appearance.
it was there? Okay. Not very.
And in the history, you asked for fever, isn't it?
Yes,
Can I
ma'am.
know why you asked for fever?
Maybe, ma'am, in inflammatory carcinomas, fever, and also, ma'am,
Carcinoma will present with fever, especially in the postmenopausal old age. What is the common age?
really, 4 less than 60 years, 40 to 60.
My opinion is don't ask everything you have it in your mind. For particular that patient, what you want to ask for particular patient only you can ask. Not
Yes, ma'am.
everything you want to know like that. You won't ask anything in the patient, no? You won't ask everything in the patient. To that particular patient, what you wanted to know, what is relevant to that particular patient only you can ask.
Yes.
I hope so. So if you have any idea of BCS following this good responders?
Ma'am, in BCS, we do the wide localization of the lung, ma'am, and following that, we can do sentinel lymph node biopsy, ma'am. And if actually,
Sentinel lymph node biopsy.
no,
Why?
in this patient, you will do sentinel lymph node biopsy.
no, ma'am, actually
Positive
already
node.
it's proven, ma'am. So no need of,
What is the indication for sentinel lymph node biopsy?
ma'am. It's, node negative, ma'am.
It should be
Like
clinically node negative.
early.
Clinical and radiological node
It's
negative only you'll
node
go for a
negative.
sentinel lymph node.
Yes, ma'am.
Isn't it?
Yes, ma'am.
Can you also told it is your for your patient the lump is present only in the lower quadrant, isn't it?
Yes, ma'am.
But you told in the examination and look for pectoralis major involvement also, right? Usually for lower quadrant you lose only for the serratus anterior, not for the pectoralis major. As a PG, you should know what is relevant to your particular patient. So it's okay, sir.
Thank you, madam. Thank you. Faculty, we have a Vishnu, do you have any questions?
No, sir.
Doubts to be clarified?
No, sir, nothing.
Thank you very much, Ishwar sir. Would you like to give your comments, Ishwar sir?
No, what are the various components of the breast conservation surgery?
Yes, sir. Yes, sir.
What are the various components of the breast conservative surgery?
So, the only wide localization of the lumps.
That's all.
That is the only thing in that breast conservation surgery?
And
No. When you offer breast cancer surgery, When will you offer it?
Ma'am, if it is early breast
No,
carcinoma,
no. What's the contraindication for breast conservation surgery?
ma'am, if tumor to breast ratio is high, ma'am,
What
and
else?
if it's not positive, and if patient is multicentricity, ma'am, multicentricity and multifocal.
Oh, no. What is the ideal absolute contraindication? Sir is asking that only.
Notes, ma'am, clinically.
No.
What is the absolute contraindication for breast conservation surgery? And what are the relative
If metastasis is
contraindications?
there.
Absolute is?
Metastasis.
No. We're not talking apples and pears. In apple to apple, absolute contraindication where I will never offer breast conservation to the patient. Which kind of patients would I never offer?
I mean,
any genetic makeups?
BRCA.
Not at this age group, but yes, that's an absolute contraindication, right? What are the any other absolute, you said multicentricity. So those two are the only real absolute contraindications for that, right?
So BCS, you tell me what are the other components? As Sir asked, no?
I mean, you can't, I got a shock if I'm only going to do wide excision and leave the patient. What else would I do?
Ma'am, and axillary dissection.
Yes, and
radiotherapy, ma'am, post radiotherapy.
Radiotherapy is a component of BCS. If the patient is not fit for radiotherapy, you cannot proceed with BCS.
So you have to give boost radiotherapy. You have to say it's a boost to the site, tumor site. That is why we clip the tumor site and then radiotherapy to the rest. So it's a boost kind of radiotherapy, right? And in all LABCs, you will do an axillary dissection, at least a sampling, proper sampling below the thing, because node positivity is high. Yeah. Vishnu, you're good. You confident, but then beach may you just disappear. I don't know, you get lost. So you need to be more focused in your answering and take questions with some kind of confidence.
How do you define the margins when you're doing a breast conservation surgery? For the help of the pathologist to tell you that which margin is positive or not. So how do you help the pathologist?
Sir, we'll put suture notes. Like,
so how will you put the sutures?
Short and long. So long lateral and short superiors.
And
deep surgical margin also will.
So how many sutures you will put at the deep surgical margin?
Only one.
But then how the pathologist will know that which is the deep one? You know, in case if we have removed the skin, then the pathologist can know that the skin is the anterior margin and probably other side is the posterior margin. But in a good number of the cases, you will not remove the skin. Then how will you know which is the deep margin? Deep stands for double. Okay, you have to put the two sutures there, the double sutures as you put. So long lateral, short superior, and double margin of the posterior side. And then the pathologist can tell you all the margins. Yes. All the 6 margins he can tell you there. No? Okay.
Can we end this now?
Yeah, I think we can. Yeah.
Any questions from you, Vishnu?
No.
Chalo, all the best.
Thank you.
Thank you, madam. Thank you, Shilpa ma'am, for staying all 2 hours. And thank you, Babita ma'am, for joining. Ishwar sir, Kanna sir, and other senior faculty who have joined. Abhay sir has left little early because he has a flight earlier tomorrow.
Yes, but we can't refuse you, Dr. Kanagavel. That's the problem. So
Ma'am, I'm humbled and honored because this forum just runs with people who are like you, who have been helping us for the last 3 years. In fact, we have had a stupendous journey. In fact, we have more than 410 cases, which is available on the YouTube.
No, it's an amazing
So-
show, and I was telling my boys, you know, if you sit down and listen to all of it,
Yes,
you'd probably be able to, you know, answer any exam in the universe. So it's a good forum.
I think we have been maintaining, and all of us are helping us to maintain the standard of the discussions also. So I think, as you rightly pointed out, if people listen to 4 or 5 cases of CA breast, I think they will have all the confidence because it covers diverse things. And in fact, few faculties have also told they listen to us. That is very heartening, ma'am, really.
The problem is my residents, you know, I finish asking all my questions here. Then when I'm taking
Yes,
the exams, I have no more questions to ask.
I
them.
understand. I understand. I understand. But then, ma'am, like
No,
more
it's
and
fun.
more.
It's fun. I enjoy it.
Thank you very much, ma'am. Thank you.
All right. Good
Anna
night.
sir and Tanai sir, any questions, sir? Ishwar sir?
No questions, sir. I'm very thankful to
Thank you. Thank you. Thank you. Thank you, Babita ma'am. Thank you,
Thank you, sir.
Karnakaran sir. Kanna sir, thank you. I could see Ratna ma'am, Karnakaran sir, Shri Hari Rao sir, others are joined. Thank you very much. We look forward for yet another Friday. Good night, everyone.
Night, sir.
Thank you, sir.